Thank you very much, Mr. Chairperson, ladies and gentlemen. It is my great pleasure to have an opportunity to contribute to KHS symposium. My disclosure information. In this lecture, rather than reviewing others' papers, I would like to discuss the practical technique for LV summit ventricular arrhythmia mapping using my case examples. I believe the most efficient method for LV summit VT mapping might be coronary venous mapping technique. This is decision 3 for LV summit VA ablation provided by Garcia. You can try endocardial ablation at the earliest technical site if it is endocardial focus. If it is the intramural focus, coronary venous mapping is useful, and you can start the endocardial ablation as opposed to the earliest execution site. If it is subepicardial focus, you need to map the corresponding endocardial site first. If wall thickness is thinner than the 14 millimeter and the time difference within 7 milliseconds, you can try endocardial ablation first. Otherwise, you need to consider epicardial or coronary venous ablation. This is anatomy of cardiac venous vein, cardiac veins organized by Valderrama. Although there are so many variations, coronary vein map is very useful for planning the strategy before entering the epicardium. Also, you can map the potential epicardial target and inaccessible areas such as septal or community venous vein area. Coronary vein map with microcatheter provides good landmark during ablation, estimating the location of coronary arteries. Even you can use coronary vein for alcohol ablation. So I recommend mapping the coronary vein for VT from LV summit based on anterolateral wall or crux areas. This is an electrogram ECG of 67 years old male patient with frequent PVC. He also has coronary artery fistula and marginal regional wall motion abnormality and echo. At first glance, it is outflow tract PVC, but you can, if you look at V1 to 3, the intercoital deflection time is quite unusually long. Lead 1 shows the DBS wave, relatively left side, the summit focus. This is LAO and RAO views taken from fixed floor angle. From left side to right panels, there are RB outflow tract angio, AIB map, septal perforator map, and aortogram. So when I encountered patient with LV summit VA, I first obtained RB outflow tract angiogram and quick read map. The next step is coronary venous mapping is performed directly through coronary sinus, and JR4 catheter was inserted in the SL1 sheaths, and AIV and septal perforator were mapped sequentially using 2 French microcatheter. But you cannot distinguish AIV and perforator in LAO view, but in RAO views, AIV comes down along the LV anterior wall, but the septal perforator is seen bent position in RAO view. So since you have to do aortic cusp angiogram before burning, you can distinguish the septal perforator and the communicating vein by distance from aortic root. If it is closer to the aortic root and above the aortic root, it might be communicating vein. But this microcatheter is a lower position away from the aortic root, so it is in a high position of septal perforator vein. This patient is a 65 years old male who attempted ablation from non-site VT. It is similar to ECG, similar ECG to the previous patient, but characterized by prominent R wave in lead 1. So even it is the same summit, it might be more septal side is suspected. These are pulmonary angio, CS venogram, AIV mapping, aortogram, and kissing ablation catheter obtained from fixed LAO and RAO views. I told you the differentiation between AIV and septal communicating vein can be done in RAO view, and the aortogram microcatheter position appears to be communicating vein as it is located just anterior and superior to aortic root. and posterior to the pulmonary artery. So in this patient, the simultaneous unipolar ablation was performed inside of a great cardiac vein and ostium of communicating vein and the endocardial side of a transaortic approach. This is 63 years old male patient with nonsense VT. ECG shows early precordial transition and a small Q wave in lead one, suggesting some septal origin. So we have to be careful about the risk of heart block. We map the septal vein and corresponding endocardial side by using the transaortic approach. We saw the 61 millisecond early activation site and microcatheter and the far field 67 millisecond earlier than cure sunset and corresponding endocardial side. We have to keep in mind focus on the local far field signal rather than the near field signal when you map the intramural ventricular arrhythmia. And as when the Job reported, the endocardial unipolar Q activation was slower than bipolar activation, suggesting intramural focus. Because the measured wall thickness was 12 millimeters, it was a typical intramural VA based on Garcia algorithm, and the PVC disappeared within 5 seconds of 40-watt endocardial ablation. However, during second insurance ablation, with 40-watt, the ablation catheter was slightly displaced to the epicardial side direction on 3D map. At this time, contact force was 20 and 21 gram, and we used 40 watt. It could be a sign of impending stim pump or already exposed to the micro stim pump. So therefore, I readjusted the catheter curvature, reduced the contact force, and completed the ablation safely. Stevenson reported the sophisticated mapping of periaortic VT in patients with non-ischemic cardiomyopathy. Periodic VT substrate were mapped over 38%, and more of the proportion of VT showing LVVB and RVVB pattern was half and half. In case of LVVB pattern, it was easy to terminate, but shows us 23% chance of heart block. In contrast, the case of RV pattern, VT target exists more laterally and shows only 70% chance of termination due to the deep intramural substrate. The next case is epicardial mapping and ablation from Summit VA. This is 15 years old boy with drug refractory symptomatic PVC with ejection fraction 50%. You can appreciate cardiomegaly compared to his age, and this shows ventricular bigeminy, RVVB, long interstitial deflection time, precordial transition 2-3, and inferior axis. Lead one shows a very deep S wave. Where come these PVs come from? In this patient, the absolutely early activation of PVs was mappable from anterolateral branch of a great cardiac vein here, but not at the endocardial side, endocardial mapping. So we mapped the endocardial area carefully with mapping catheter. You can appreciate the far field V potential near the epicardial early activation site. When you map the intramural epicardial focus from endocardium, you have to carefully observe the far field potential. But I could not find out the better endocardial activation site than this point. So I hesitate to burn, but I did. I used half normal cell line 45 watt 2 minutes, and there was absolutely no change. So what is next option? There are so many options. In other words, there is no proven best option because nobody wants to generate a big scar in this young man. I chose the epicardial ablation instead of extensive burn or alcohol ablation. So using the pentarite catheter, we found the earliest activation site on the epicardium. This is a carto epicardial map. There was a discrete activation near the low voltage area. I do not know whether it is scar or epicardial fat, but that there was a very, very low voltage potential 90 milliseconds earlier than the current sunset. In this EGM, the proximal electrode is earlier than the distal electrode. Therefore, it may be near the coronary venous mapping site. So I decided to burn the epicardium before RF panels delivery. What should we check? It is mandatory to check coronary angiogram and fragment capture. Coronary arteries are separated from VT target site. However, especially in the condition under general anesthesia with neuromuscular blocker, you have to be careful about the fragment injury. Because I felt fragment capture at the target site, so I carefully moved the ablation catheter a little bit to the safer area. However, we experienced fragment capture during RF panels delivery. So it was not a pacing-induced fragment capture, but the RF panels-induced capture. So I stopped burning all of a sudden. So what should we do next? There are two ways to avoid the fragment injury in this situation. The first one is filling the pericardium with saline, 80 to 150 milliliter. If the fragment capture threshold is less than 5 mA, you can try it again. However, if capture threshold is higher or lower or still has a risk of injury after filling the pericardium saline, we need to use larger volume to separate the epicardial surface from fragment nerve. So we could eliminate PVC at the epicardial target site after pericardial saline filling, and the finished case was happy ending. The last case is LV summit VT with cardiomyopathy that failed despite multiple procedures. This patient is 62 years old, male patient with lamin and titin mutation cardiomyopathy, ejection fraction 35%, multiple IC shots. He underwent first a VT ablation from another hospital, but we did multiple further procedures after referral. VT target at the first and second procedure were LV summit and also ablated scar border joints at mid-post septum. Final ablation was done in mid-anterolateral epicardium. And although the frequency of IC shock decreased remarkably, but still he has occasional ICD therapy, so we included him in the transplantation list. The patient shows so many different VT morphologies, 1, 2, 3, 4, 5, 7. Even after sympathectomy, ICD shock was occasionally repeated, and most documented VTs were LV summit origin. Accordingly, stereotactic body radiation therapy was performed in consultation with radiation oncologist based on our previous performed 3D maps. When we conducted radiation targeting, the bony structure and CRT-LV lead provide essential landmarks. Radiation oncologists accurately calculate the target volume of the LV summit and completed SVLT within 30 minutes without pain or invasive interventions. There was a VT with ATP termination in about 2 months, but there has been no further ICD shock so far. So I'm carefully watching the following his rhythms. This is my take-home message. Coronary vein mapping provides an excellent landmark for successful LV summit ventricular arrhythmia ablation. Multi-view mapping, especially aerial view, differentiate AIV, septal perforated and communicating vein. Careful watching for far-field signal is a key to targeting the intramural VT. Coronary vein or epicardial map may visualize intramural VT targets. General anesthesia may suppress ventricular arrhythmia or fragment capture, and SVLT could be another option in patients with ablation-resistant recurrent VT. Thank you very much for your attention.